reminders so that we are not forgetting where we've come from. When you look at the course, it's divided into parasitology. This is microbiology divided into parasitology, bacteriology, mycology, and virology. When you look at parasitology itself, the study of parasites, it is further going to be divided. You are going to be studying what we call so you are going to be studying protozoa, you are going to be studying metazoa, and then you are going to be studying the arthropods. Protozoa, these are single-celled organisms. Metazoa, these are worms, right? Worms. We call them as helminths. And then we have got arthropods. Arthropods, these are guys that carry disease. For example, a mosquito. So a mosquito is an arthropod. I hope that makes sense. So that is the basic thing you need to know. It's actually important for you to know how to be able to split the course so that you'll be able to follow it properly. Now, when you look at protozoa, we have got those that have got no flagella. We call them amoeba. And these are the ones that you discuss for example, Entamoeba histolytica, Naegleria fowleri, and Acanthamoeba. And then you have got flagellates. These guys have got flagella. So how do they look? They are going to be something like that, but these guys don't have any flagella. When you look at the flagellates, you have got those that are found in the intestines and in the urogenital tract. Okay, so you have got the intestinal flagellates or the urogenital flagellates, and then you have got those that are found in blood, which we call hemoflagellates. So when you look at these guys that are found in blood, the hemoflagellates, we have got the trypanosomes and leishmania. These guys are going to have some features that are similar because they are both found in blood. And then those found in the intestines and the urogenital tract, you have got Giardia and Trichomonas. We already discussed Giardia, we'll discuss Trichomonas later on, and Leishmania. So after Trypanosomes, we'll go to Leishmania and then we'll discuss the Trichomonas. I hope we can be able to get that. It's important for you to be able to move in order like that if you want to understand the course itself. Right? So let's discuss blood and tissue flagellates or the hemoflagellates. The first thing I'm gonna describe for you the overview. You use the notes for to study. So when you look at the structure, the morphology for these hemoflagellates, they are going to have different morphological forms. I want you to understand first the morphological forms for all of them. Okay, and then you can now get, because for each species is going to have a different combination of the morphologies. Okay, so these guys are going to possess a single nucleus, what we call a kinetoplast and a flagella. So let's say this is the structure like that. They have got one nucleus like that, and then they are going to have a kind of kine kinetoblast. So a kinetoblast, you'd see it as a dot there. A kinetoblast consists of what we call a parabasal body. Okay, it is dot-like in appearance. And then you are going to have also a flagella coming out. This is the basic structure for an hemoflagellate. You have got four different structures or four different morphologies into that you can find for these hemoflagellates. The first morphology is known as the amastigote. Please, we need to differentiate them, right? Remember when we discussed the what? Intermeba histolytica, we said that you have got the cyst, you have got the trophozoite, right? The trophozoite can either be amoeboid. Okay. So for these hemoflagellates, you don't have a trophozoite. Instead, you have got the amastigote. That's number one form. Number two form, you have got what we call the promastigote. Number three form, we have got what we call the epimastigote. And then the last form is what we call the trypanosomes. So you need to know how to differentiate these structures. When you look at the amastigote, well, think as mascot, as to you don't have an, right? So these guys, in appearance, they are oval. You are going to see the structure like that. And then the nucleus is in the center or the side of the cell. So let's say the nucleus is there. And then you have got a kinetoblast, okay, or a kinetoblast. That's dot that you can see here. When you look at the amastigote, it has got flagella, but the flagella is not outside. So it doesn't have any external flagellum. This is the anterior side, and this is going to be the posterior side. Now, the way I've even written this is, let me say, this is the anterior side, this is the posterior side. You know why? This gamma thing here, which we are calling as the kinetoplast, is anterior to the nucleus when it comes to the amastigote. And we have said that the flagella is inside. This is the nucleus. And then this gamma structure is the flagellum. I hope that makes sense. So that is the basic structure of the amastigote. When you look at the promastigote is slender. So you are going to see the shape like that. Okay. And another thing is the nucleus is central. You are going to see the nucleus at the center. Besides that, the kinetoplast is also anterior to the nucleus. Okay. So here, so this is again going to be the anterior side, this is the posterior side, and it's from the kinetoplast that you're having the nucleus extending. Let me write it somewhere here. So I've got the nucleus coming out of there. Okay. So that is how this guy look. Now you not only see one kinetoplast, you can see two of them or three. Let me put like that. I hope that makes sense. And then the other form is the epimastigote. The epimastigote is even more elongated than the promastigote. So you see the shape is even much longer. Like that. Forget about this part here. Okay. Now for this guy, it is more elongated, and at the same time, the nucleus is still going to be posterior to the kinetoplast. But the kinetoplast is just anterior to the nucleus. And you know it's from this guy that the flagella extends. And the flagella is going to run along the body of a short undulating membrane before emerging from the anterior end. So what we are saying is that you are going to have a structure going like this. You can see it is moving along the membrane, and then it comes out from the anterior aspect. So we call this as the undulating membrane. Okay, the surrounding membrane there. The promastigote doesn't have the undulating membrane. When you look at the trypanosomes, It is different from the pro and epi in that the nucleus is going to be the one that is anterior, the promascot is going to be posterior, and then from there you are having the flagellum to extending from there, and then it goes anterior. So the flagellum still comes out from the anterior aspect, and it will also run alongside the entire length of the body to form a long undulating membrane before emerging from the anterior end. So just the moving of the flagellum around this membrane, that is what we are calling the formation of the undulating membrane. Okay, where it's moving like that. So please, these are the morphologies of the hemoflagellates. So depending on the type of hemoflagellate that we'll discuss, might have different combinations of these morphologies. So we are not saying that all of them, all the hemoflagellates are going to have these combinations. No, they are actually going to have different combinations of the amascot, promascot, epimascot, and trypomascot. I hope that makes sense. I hope that's clear. It's important for you to understand that. Is there any question? Is there any question? Okay. So again, we are saying the hemoflagellates, these are flagellates that are found in blood. And here we're not discussing leishmania, we are just discussing the trypanosomes. When you look at the trypanosomes, they cause trypanosomiasis, sleeping sickness, trypanosome. And when you look at these guys, we can divide them. They have different species. So for the species, we can divide them into two main ones that we are going to be able to discuss. We have got trypanosoma brucei, and then we also have trypanosoma cruzi. When you look at trypanosoma brucei, this guy is going to have subspecies. So you are going to have what we call trypanosoma brucei, that's a subspecies, and then you have got the trypanosoma brucei gambiesi, and then you have got the trypanosoma brucei rhodiense. So these are the subspecies: brucei gambiesi, brucei rhodiense. And then we also have the trypanosoma crus. I hope that makes sense. When you start looking at the trypanosoma brucei, the and you look at the morphology, let's start with the brucei. You need to know the differences because these guys are different in location and the disease that they are going to be able to cause. Trypanosoma brucei, when it comes to the morphology, it exists in vertebrates. Vertebrates includes humans. So for the vertebrates, you are going to find the trypomascot. Remember the trypomascot? That's a guy where the membrane was coming from the posterior aspect and then going behind from the kinetoplast, because the kinetoplast was the anterior to the nucleus. So the shape that you are going to find in vertebrates is the trypomascot. And this trypomascot is actually going to be found in three forms. It's important for you to understand. Remember, vertebrates includes the human. So this is the form that you're going to be able to see in humans. So you have got the long, slender trypomascot, and then you have got the short, stumpy, okay, trypomascot, and then you have got the intermediate form. These are the main forms for the trypomascot. Of course, these guys have got flagella. Now, when you look at the life cycle for Trypanosoma brucei, remember for brucei you have got brucei gabiense, brucei rhodiense. When you look at the life cycle for gambiense and rhodiense, they require these two guys. They require two hosts, okay, in order to complete their life cycle. One of those hosts is going to be the human and other vertebrates. So humans are actually the definitive host, or the vertebrates are the definitive host. There's only one common guy where humans are the intermediate host, and that is the guy that causes malaria. Anyone who knows the parasite that causes malaria? What parasite causes malaria? So the Plasmodium species. Okay. So the definitive in the Plasmodium species, the definitive host there is human. But in most of the other species, the definitive host is going to be, sorry, the intermediate host in malaria, or yeah, in malaria Plasmodium, is going to be the human. That's the intermediate. But it's opposite, because humans mostly act as the definitive host. Please take note of that, it will save you a lot. Most of the parasites, if you see them, just know that human is the definitive host. One biggest exception you need to know is Plasmodium species, where human is the intermediate host. So the intermediate host again for Trypanosoma gambiense and rhodiense is going to, so the intermediate host is going to be the insect. Now specifically, what insect carries the trypanosomes? There is a hand. Yes, please. Yes, if there are going to be others, there are going to be really few, but of the major ones that we discuss, the definitive host is human, beside except the Plasmodium. There are going to be few ones which we don't pay much attention to, but of the major ones we discuss, that rule, if you know it, it can actually save you, because majority of them are going to meet that same principle. Good. All right. So when you look at the intermediate host, we are saying that these are insects. Now, specifically, which insects? So you have got what we call the flies. These are the insects that will be acting as the intermediate host. Now, to be specific again, these flies, they have got different genus. Okay. So to be specific, the fly that is going to transmit Trypanosoma brucei gambiense rhodiense is the of the genus Glossina. Glossina. It's important for you to understand this. The genus is Glossina. Supposed to be A at the end here. All right. So again, you need to know this. Both the male and the female for this guy is going to cause infection. So both male or female bite of this fly can transmit infection. It's different from mosquito, where only the female Anopheles mosquito can cause infection to man. And when you look at these guys, you need to know what is the infective form to man. What is the infective form for the parasite? So the infective form is what is known as the metacyclic trypomast goat. This same common trypomast goat that you can see here, because that's the one that will be found in the definitive host, but we call it the metacyclic trypomast goat. Okay, hope that makes sense. So that is the basic thing. Now, how is infection going to happen? For you to carry infection, so that how is infection going to happen for you to be able to get this guy, the trypanosoma brucei? So what is going to happen is that the metacyclic trypamast goat, this guy is going to be first introduced into the definitive host. Okay, metacyclic trypamast goat, mast goat is introduced in the definitive host. So is in definitive host, and by whatsoever mechanism which it is going to be transmitted, we are going to talk about how they are actually the mechanism by which these metacyclic trypamast goat can be transmitted or be given to the definitive host is via the bite of the the fly, either female or male, of the genus Glossina. And once that happens, the trypamast goat is going to now get to first, it has entered at that place where there is injection. It is going to enter and then it is going to transform. So trypamast goat is going to transform into the long. Remember we said the trypamast goat has got three forms: the long slender, the short stumpy, and the intermediate. It is going to transform into the long slender shape or form. Once it transformed into this long slender form, the next thing is that this guy can now convert into the intermediate form. After converting into the intermediate form, this intermediate form is then going to convert into the short stumpy form. So you can see from long to intermediate to short. Once you form the short stumpy form, then what is going to happen is that parasitemia occurs. What is parasitemia? Is you having a lot of parasite in the body. So the number of parasites that are now increasing in the human body. So when parasitemia occurs due to the invasion of blood serum, in other words, what we are saying is at the point of bite, right? At the point where you've been bitten by the mosquito, this guy is the long slender form entered. By the time you are converting into the short stumpy form, this short stumpy form is now going to go into blood. And when you have got parasite in blood, that is known as the parasitemia. Okay, so once you have got parasitemia, this gas entered in blood, the shortest stumpy form are now going to be sacked. So are going to have the second fly coming to beat you. Okay, so the fly is going to now come, and fly comes and sucks the blood from you. Remember, the first fly was introducing the infection. This second fly is coming to get the infection from you who is infected already. And once that happens, the short form is going to go to the, remember, the fly is taking what? Is taking the short stumpy form from the human. So the short stumpy form is going to convert, short form is going to convert into another form, and this is actually inside the fly. The short form is going to go to the mid gut, because when it is chewed, it first goes in the foregut, right? The mouth is part of the foregut, and then it is going to go to the mid gut of the fly. Once in the mid gut of the fly, what is going to happen is that this guy is now going to develop into the intermediate form, and then the long slender form, and then start multiplication, okay, to convert into the long slender form. Once it develops into that, then it starts to multiply. And once they start to multiply, this is happening all in the insect, the long slender form is going to go back to the salivary glands of the insect. Okay? And then once it goes back to the salivary glands, this is, remember, for the insect, salivary gland, it is going to convert into another form which we call the epimastigote. Okay? The epimastigote. Once you formed this epimastigote, this epimastigote is going to attach now to the cells of the salivary gland, and then there they'll start to multiply and then transform into the non-dividing metacyclic form, which is a metacyclic trypomastoid. So the metacyclic trypomastoid actually does not divide, and this will still be there in the salivary glands. And what is going to happen is that when a mature s- uh, one of these guys, the metacyclic trypomastoid, when it matures, it is now going to detach from those cells where it is holding in the salivary glands. So it is now going to be released once the fly beats another person, and it goes back to where we started from. Okay, so we are saying that the form that is found in the insect is the epimastigote. The form that is found in human is the metacyclic trypomastigote. I hope that makes sense. Is there anyone that is left behind? Are we okay? Okay, good. Now, what infections are caused by these guys? You understanding just a life cycle. What I've just described is the life cycle. That's the life cycle. So the life cycle, we said this was only for T. gambiense and rhodiense. Life cycle happens in both the insect and human. Understanding the life cycle will not tell you the disease process that happens. Okay, what disease? We know that it causes trypanosomiasis, causes sleeping sickness. But then, how does someone know? How does that present really the sleeping sickness? So again, remember we are saying we have got these trypanosomes. I can actually write this one on top here, just here. So we have got the trypanosoma brucey-gambiense and brucey-rhodiense. So what sicknesses do they cause? When you look at the trypanosoma brucey-gambiense, this guy is actually it causes what is known as West African trypanosomiasis. West African trypanosomiasis what? Okay, which is sleeping sickness. Rhodiense will cause East African trypanosomiasis, which is also sleeping sickness. So that is it. East African trypanosomiasis. Okay, how are you going to remember this? In case you know the map of Africa, how do you even draw the map of Africa? Something like that. Something like that. Think of Gambia. Gambia is somewhere this side. So that's West African trypanosomiasis. Okay, think of Ara. Ara is pointing where? Is pointing this side. That's the, which side is this? This is the east. So East African trypanosomiasis. All right. So make sure that you take note of that. The incubation period is the time between the bite of the insect to the period when you start having symptoms. Incubation period is usually 2 weeks. I mean a week for this one. So what happens is that at the point, what are some of the clinical features? At the point where you've been bitten by the fly, you are going to have the development of what we call, so we are talking about clinical presentation. For someone, how are you going to know that, okay, this one has got sleeping sickness? So clinical presentation. This is what we call medicine. So for medicine, you're supposed to know not only the condition, but how do you tell that, okay, this one really has got this condition. For example, you discuss in pathology chronic bronchitis and emphysema. Those are two conditions in chronic obstructive pulmonary disease. So how do you know that this one has got chronic bronchitis, this one has got asthma? How are they going to come to the hospital? What are they going to be complaining about? So at the site of bite, you are going to have what we call a chancre or a chancre. A chancre is a lesion that you'll be able to see at the point of the bite. If you've had a very big sore on your body before, a very big sore, when it is healing, you have got that hard part that remains when a big sore is healing. So something like that, a hard and tender portion. Okay. Besides this, when this chancre remains, if it is untreated, or after the first point when you were bitten, but the condition was not treated, you can have also the involvement of the central nervous system. So I'm going to have CNS manifestations. It is actually the CNS manifestations that are responsible for sleeping sickness. So there's going to be progressive neurological impairment. Someone is going to actually be forgetting things and they can't control themselves. They'll be sitting here, maybe you are talking properly, and then someone just goes and then they have slept. And that they can actually even go into a coma and end up in death. Other features that you'll be able to see for you to tell that someone has got the involvement of the central nervous system is a headache, okay, the inability to concentrate, the change in behavior, someone becomes aggressive, even to daytime sleeping. And then the patient may actually fall asleep while sleeping, while standing, while sitting, while walking. And in the final phase, it can end up in coma and it can cause death. Is there any question? Okay, I hope that is okay. Now, someone has got sleeping sickness. How are you going to confirm? Besides you, because it's not only sleeping sickness that will cause these neurological problems. How are you going to confirm that really, okay, this one is just this disease? You can do some labs to diagnose a condition. So, lab diagnosis. For the lab, some things that you can, for the diagnosis, some things that you can look at is blood. And what you want to identify is you want to identify the same morphological forms that are found in humans for the parasite in blood, because you'll be able to see them there. I'm going to show you a picture. You can as well get a lymph node aspirate. An aspirate is you penetrate the needle through a lymph node, you get some cells, and then you get to view it. Beside lymph node aspirate, you can also do a bone marrow aspirate. Okay, that can also help. You can also look at cerebrospinal fluid, because for you to start having these central nervous system manifestations, it means that something has gone to the central nervous system. And you can also, at the point where you were bitten, where there was a chancre, you can also get the aspirate there. So fluid aspirate from the trypanosomal chancre. You can as well get that. You can also do microscopy where you get those cells and then you put them under the microscope. You want to view them. So this was Trypanosoma brucei. Remember we said we have got brucei and we have got cruzi. Now Trypanosoma cruzi, this guy causes what is known as Chagas disease. Different from the sleeping sickness caused by the brucei, Chagas disease. Okay. It was actually named after the one who discovered it in 1909, Carlos Chagas. Now, this guy, the two morphological forms, remember the morphologies for Gambiesi and Rhodiense was the epimast goat, and so this here, there was the epimast goat. That's the one that you find in the intermediate host, epimast goat. But when it comes to Chagas disease, the morphologies that you are finding here, you have got the trypomast goat and you have got the armast goat. That guy that didn't have a flagella that was outside. Okay, the armast goat. The way the trypomast goat looks is, a trypomast goat looks like something like this. It looks like a structure like that. Okay, and then you have got the nucleus there, and then you have got common structure there. Okay, that's a trypomast goat. I already showed you another form where it was slender in appearance. This one is even more bent. So when you look at the life cycle of trypanos, do I have got an empty space? Okay, I've got one page. I hope it is gonna fit for Trypanosoma cruzi. So I'll put T cruzi. Please, in case you are left out at any point, be free to ask. Now, when you look at Trypanosoma cruzi, this guy passes its life cycle in two hosts also. Humans, as usual, someone to guess. Are humans going to be definitive hosts or intermediate hosts? From what I've been mentioning. Very good. Okay. So humans are going to be the definitive hosts. And then the intermediate host is going to be also a bug. Now it is known as a tritominic bug or redovid bug. Hope you'll be able to pronounce that well. So this guy is the one which acts as the intermediate host. So make sure that you know that word, especially Redovic or triatomi bug. You'll be able to see that in a multiple choice at one point or the other. The infective form for this parasite is again the metacyclic trypomastigote. Metacyclic trypomastigote. Okay, there. So how is the life cycle going to be? So humans are going to get infected when this Redovic bug bites, okay, and infect. What happens is that because the bug itself is going to get the infection from infected fecal matter, okay. Actually, not really infected fecal matter, but what is happening is that the bug contains Should I put that now? I'm just thinking I might not have enough space for me to write the entire life cycle. Let me just describe it. So there is a bite, that's the first thing. But this guy is tricky. Once it bites you, what it does is that it releases fecal matter. And what it will do is that that point where it has bitten you will start itching. And you are going to start scrubbing. Now, as you get to scrub, or as you get to, touch that area because it is so itchy, you are actually making the guy, the the trypanosoma cruzi to enter your body. So the infected feces are going to be rubbed onto the wound where the bite was. Okay? So the infected feces are rubbed, infected feces rubbed over the wound. And what happens is, once you rub over the wound, you have found a privilege. You have found a privilege, and this guy is going to enter the wound. So the metacyclic trypomas gut is going to invade what we call the reticuloendothelial system. So can I just say metacyclic trypomas gut empty so that I can use short form? So the metacyclic trypomas gut is now going to invade the reticuloendothelial system. Anyone that can give us an organ that belongs to the reticuloendothelial system? Any? Pardon? So we have got things like the liver, okay, bone marrow, where you find the blood cells. So we have got the metacyclic trypomas gut invading that system. And once that happens, the next thing is that it's now going to convert to the amassed gut form. Convert to amassed gut form. From the amassed gut form is going to multiply, and these guys multiply by binary fission, not fusion, fission. And then it's going to go to the promassed gut and then epimassed gut. So from amassed gut to promassed gut and then epimassed gut. And then this guy, the epimassed gut, is now going to convert into the trypomassed gut, back again into the trypomassed gut. So it's APE. You know, ape. Amassed gut, promassed gut, epimassed gut. And then back into the trypomassed gut, so you can put a T in front because you started with a T, right? The metacyclic trypomassed gut. So tape. Or you can even put a T at the end, tape it. Because again, you are forming the trypomassed gut at the end. Just that it's not a metacyclic trypomassed gut. Once that happens, another Rudivid bag is going to first the trypomas gut is now going to be released from the reticuloendothelial system into blood. Okay. So say released into blood from the reticuloendothelial system. This guy now, when a second Rudivig bag bites that person that was initially bitten, that second bite is you have gotten the the insect has gotten the trypomas gut. Once you get the trypomas gut, you again convert, you go back from trypomas gut to amassed gut, and then from the amassed gut, now this is going to be in the foregut. Okay, trypomas gut is going to be converted into amassed gut in the foregut. Differentiate from the other one that was being converted in the midgut. That's important. right? This is happening in the foregut. So second bite, and then trypomasgot is converted into a masgot in the foregut. And once you have the A masgot can convert again to the epimasgot, and then it will go back into the metacyclic trypomasgot. And the metacyclic trypomasgot is the infective form to human. Okay, so from the amasgot we went to epimasgot and then to the metacyclic trypomasgot, which is the infective to human. And it means that this other Ludovic bug can now infect another human being. Okay, so the infective forms are actually excreted in feces. This metacyclic trypomasgot is going to be in feces. Now it's different from Brucey. We said it's actually going to be the bite, right? Once you are bitten, it is that bite because it's the salivary glands of the insect, the sesafly, that contained the metacyclic trypomasgot. But here the metacyclic trypomasgot is actually found in the feces. So what happens is that the guy is going to bite you. It bites you. At the same moment it bites you, it also defecates on you. And then because you're feeling the pain from the bite, you start scrubbing yourself, rubbing yourself, not knowing you are rubbing the fecal matter, and then the metacyclic trypomasgot can enter your body. So it's very, very clever. All right. So that is what happens. And then what is the pathogenesis or the clinical features? If someone has got a disease, cause what we are calling Chagas disease, how are you going to know? What are the clinical features? So on the clinical features, this guy causes actually what is known as Chagas disease. Chagas disease is also known as South American trypanosomiasis or Chagas disease. It's South American, not African. So it is going to have two problems. You are going to have the acute infection. If we say an infection is acute, what we mean is that it hits you there and then you start having bad manifestations. For example, you are just breathing properly and then suddenly they block your airways. What is happening is that you stop breathing and then you can suddenly die. That is acute. But something that is chronic is it's been there for long and you've managed to live with it. So what are the acute features of this disease and the chronic features? So for the acute features, you're going to have subcutaneous inflammatory nodules that develop at the site of entry. So that is known as a chagoma. Remember in the other one we had a chanker, but here we have got a chagoma. A chagoma is just an inflammatory a nodule. So it's like a raised point on the skin where you are being bitten. Now, when entry is through the conjunctiva, that's part of the eye, the patient will develop painless unilateral edema and conjunctivitis, and that is known as Romanian sign. I haven't included the picture, but immediately we are done with this class, I want you to go on Google and search Romana's sign. You are going to see someone has got a swollen, like the eye is swollen. So this is unilateral. If someone comes to the hospital and then you are seeing one eye is inflamed, is swollen, you'll be saying, "Oh, this is Romana's sign." Okay, Romana's sign is associated with what? It's Chagas disease. What causes Chagas disease? Oh, it is actually Trypanosoma cruzi. Okay, so that is how you tell. So other features in acute infection, you are going to be able to see some fever, And then generalized edema. So someone has got too much fluid leaking out of the blood vessels. Okay. And patient may die of acute myocarditis and meningoencephalitis. So death is going to be called acute myocarditis. Acute conditions are bad. Myocarditis, this is inflammation of the myocardium. Okay, even meningoencephalitis. Now, meningoencephalitis are actually two conditions there. Encephalitis. There is the inflammation of the meninges, the pars mater, the dura mater, and the arachnoid mater. That's it. Meningitis. Encephalitis is now the inflammation of the actual brain. So some things that you see if someone has got meningitis is there's and encephalitis itself is there is actually disturbance to the where you wake because the brain is being disturbed. So there is neurological disorder, there is confusion, there is fever. For meningitis, you also have what we call a characteristic feature is stiff neck. You learn that when you talk about meningitis in bacteriology and virology. So there is a stiff neck. So these are features. Now for the chronic disease, you are going to have cardiac changes that are most common. Okay. So you are going to have some changes in the heart, cardiac changes. So the patient may develop dilatation of the esophagus, that's known as mega esophagus, and also megacolon if the infection has been there for long. Mega esophagus and megacolon. Remember, if someone is born without the mesenteric plexus, we talked about this Hirschsprung disease. If you remember from the development of the GIT, what happens is that someone has got no nerves, right, on the peripheral end there. So what happens is that you can't push away the feces, and so the feces will be accumulating on the distal end, and that causes the colon to be big, megacolon. So this, my friends, is what we call Chagas disease. And for you to diagnose the condition, look at what is being affected. Because we said that the parasite is going to move from the reticuloendothelial system to go into blood, and then from there it is now going to be causing all these problems. Can go to the central nervous system. So therefore, for you to diagnose the condition, you can look at blood, look at the cerebrospinal fluid, also the chagoma, you can get a tissue there. Okay. And then for the treatment, there is no actually specific treatment, but you can use something like benzimidazole for the acute infection. Benzimidazole. So this, my friend, is what we call the trypanosomes. This wasn't supposed to be for one class, but I've discussed it in one class and we've done everything. There's just one picture that I want to show you. So for the notes now, be able to read. You can see this is how the trypanosomes look. Okay, those shapes that we discussed. So this is what you're going to be able to see in blood when you want to diagnose the condition by doing microscopy. And the way I was drawing my Africa, you can see I put the P the opposite direction. So supposed to look like this, isn't it? Not the way I wrote it the other side. So even the drug that I mentioned, no, it's a P. Make sure that you follow this kind of order. Okay. Those two drugs, the pentamidine. So the pentamidine is going to be for what? Is going to be for West African trypanosomiasis. So this is what we call the tsetse fly that is going to be causing sleeping sickness. And then this is the Glossina morsitans, the Glossina species that causes sleeping sickness. So this is again one feature that you'll be able to see for someone that has got that has been bitten, or someone that has got sleeping sickness. We call it the Winterbottom sign. So these are the features. Okay. So in stage one of the disease, this sleeping sickness in stage one, In stage 1, you don't have the involvement of the central nervous system, but you have got a Winterbottom sign. There is actually hepatosplenomegaly. The spleen and the liver will become big. Lymphadenopathy because of the involvement of the lymphatic system. Okay, specifically the posterior cervical region lymph nodes. That's why you can see the Winterbottom sign. Inflammation of the myocardium, myocarditis. This feature, of course, is also seen in Chagas disease. You also have hematological features. For example, anemia, leukocytosis. This is the increase in the number of white blood cells, and thrombocytopenia, the reduction in the platelets. And this is a chanker that you can see here. So this was the point at which this person was beaten. For stage 2 of the disease, this is where you have got the involvement of the central nervous system. So there is headache, mental dullness, apathy, daytime sleepiness. Okay, you just feel like sleeping every time. Chronic meningoencephalitis can get to develop, and some of the features of meningitis include a raised intracranial pressure, the priocytosis, the increase in the number of white blood cells, and then the raised total protein concentration. So if you look at cerebrospinal fluid, you will notice that there is actually a lot of proteins, a lot of white cells, raised intracranial pressure. You'll be able to tell. So this table is giving us the differences between West African trypanosomiasis and the East African trypanosomiasis. Okay. So again, you can see for diagnosis using the gene sustain, you'll be able to see trypanosomia brucei in a blood smear, and then you'll be able to diagnose them. So not only rhodiense, of course, also the other one. Some findings, if you want to diagnose, if you see anemia, monocytosis, the increase in just one type of cell, that's monocytosis. Cytosis means increase in number of cells. Mono, one type of cell. Let's say, for example, only the macrophages have increased in number. There's also going to be increased erythrocyte sedimentation rate because you are producing a lot of gamma globulins. Reversal of albumin globulin ratio, increased CSF pressure, raised cell count and proteins. Those are non-specific. For the treatment, as I said, you have got pentamidine, which is a choice for Gambiese. All right. Remember, Gambiese was East African. So remember, I said Africa is supposed to be like this, not the way I drew it earlier. So the kind of P we are drawing is supposed to be like this. So penta has got a P. Okay. So, and remember the West African trypanosomiasis was caused by Gambiense. That's what pentamidine is used to treat that, and then suramine is used to treat the one caused by Rondiense, which is East African trypanosomiasis. And then for patients where there is involvement of the central nervous system, the CNS, that is stage 2 of the disease, you use melasopro. Okay. You can also give fexinidazole for both Gambiese. This one is for both stage 2 and stage 1, where there is involvement of the CNS and where the CNS is not involved. Okay. So this, my friends, is trypanosomes. Next, we are discussing leishmaniasis. Thank you so much for being present to this end. Mm, I'm going to ask you in case you have got questions.